I wanted to talk about diffuse large B-cell lymphoma because it's the most common lymphoma we see. If we just look at the whole big family of DLBCL, the relatively good prognosis ones, which we don't see a whole lot of, are lymphoma to granulomatosis. We see a fair number of mediastinal large B-cell lymphomas. Those behave very well. The intermediate category are those with a low proliferative rate or the germinal center derivation. And then you've got all these bad actors down here. We're going to focus mainly on the non-germinal center or the activated B-cell type, but also the Burkitt's and the double hit. I rely on these NCCN guidelines for almost all tumors now because it's some consensus about what the community is doing overall. And oncologists are also looking at these. And lastly, these are therapies. We all know about rituximab, but one of the two things that are popping up now, CAMPATH, anti-CD52. This is a great chemotherapy for T-cell lymphomas, but also some B-cell lymphomas. You also see that I'm asking you to order a CD30 on all these DLBCLs because it has an excellent response to rituximab, particularly in a relapse setting.
A 71-year-old female, they tell me mass from vagina, and that's really all I've got. So they're high-grade cells. I don't know if you guys can see the, they're really ugly nucleoli. There's a lot of mites here. Anyway, P53 was patchy positive, P16 was positive, CEA negative, Vimentin positive, 20 positive patchy, CK20 negative, Ki67 was positive, about 30% proliferation. So we call the high-grade malignant neoplasm with clear cell and papillary features, pending review by UCLA. I talk about the, what it looked like, the immunos, and then I said the overall cytomorphologic and immunophenotypic features raise a differential that includes urinary and gynecologic primaries. However, given the limited number of stains that we have at our disposal, the case is going to be forwarded to UCLA.
But we're going through the biggest change in practice that we've ever seen before. That is, when to transfuse versus when not to transfuse. Okay, what has changed in the last 10 years? Regulatory oversight is much higher. We've had, as I mentioned, some better randomized prospective study. The medical legal considerations are based on doing no harm but having some adverse outcomes. And these have all led to a change in the transfusion criteria. So I give you the reference for these multiple randomized prospective studies. We are now in the process of two things. No longer can we order twinsies. So it used to be, I had this talk 20 years ago and I said, it's not a good idea to automatically order 2 units of blood or 3 units of blood. Give a unit of blood and then see how the patient is doing and then order another one. This is formalized now. The Joint Commission is going to start to require that a note and a laboratory value be on the chart in between the first unit of blood and the second unit of blood. So that's part of the program that they're asking the Department of Pathology to put together. You need a note and you need a reason and an evaluation. Where are we today post-surgery? If the patient is stable, it's a hematocrit of 24. That's a huge change. Now, the nuances, if the patient has acute coronary syndrome, any kind of note that says we suspect a heart attack or coronary ischemia, transfuse up to 30. Now, the area that's hard to assess is if the patient has cardiovascular disease, coronary vessels that are calcified. It's a judgment call whether you think the patient is unstable, and if the patient is greater than 65. Okay, medically stable, a hematocrit of 21 with judgment to 24. Chronic cardiovascular disease, 24. A medical case, 65 years older, elderly with chronic cardiovascular disease, 24 to 30. And medical acute coronary syndrome, I would advise to transfuse up to 30.
All right, so today I'm going to talk about solid tumor FISH, and I'm going to go over some of the more common assays and tests that we run, some of the probes we use, some of the gene products, and I'll also go over briefly, really conceptually, the types of molecules, the types of cascades that we're talking about. So very broadly, the role for genetic testing in cancer is increasing. And it can give us, as Dr. Harris mentioned in his presentation, I noticed, gives information about the diagnosis itself, particularly as we see in hematology, prognosis, and also with the advent of targeted therapeutic agents. So these are the major pathways via extracellular signals and intracellular cell signaling that we arrive at cell death and cell proliferation that we know about. Two things to note about this are, first of all, this is probably the tip of the iceberg when it comes to the number of proteins that are involved in cell signaling. And it makes sense, right? Because we have everything from the patterning of the immune system, selection of certain clones, apoptosis. This has to be very well regulated. Also with cell growth of the embryo. But what we're talking about mostly is in oncology. Things that affect cell proliferation would be of interest. And all of these would be potential targets, or proteins they're related to would be potential targets for targeted therapies in cancer.
All right, so to me, digital pathology is no longer a nice to have. It's essential to be competitive. Hey, we all know tumors are heterogeneous. If you're signing out the HER2, you do not look at one field and say the HER2 is 2+ or the HER2 is 3+. You got to look through the whole thing to see what the true score is. And so mitotic activity varies, as we know, dramatically from one part of the breast biopsy to another. And this technology allows you to not just average, but to show the areas of the hot spots that have the most mitotic activity that you might want to zoom in on. All right, and the same thing, you can click on an area and it'll come up with its panel of positive stains showing you the difference between some areas are 3+, some areas are 2+, and some areas maybe 1+ HER2 staining. All right, so each of these H&E images become a phenotype, like a fingerprint of this patient and their disease. The one I use is a company called Magnify. It's about $90 or so. And basically it's a case with a lens adaptation thing, and you just slide your phone in. Different models are made for different types of cell phones. You hook it up to, there's a little clamp there, you just attach it, and now you can start taking pictures, right off your, and these are what the pictures look like. I mean, they're really good. Then you take your card, and one side is a heart, and the other side is a person. So if you take the heart and put it on here, it reads, and it breaks the heart into 3 beats. On top, and you can turn on the blood and the ventricles, on and off. You can say, turn off the veins and the arteries, and you show the blood going through there. So consider this glass slide. This is my kind of big finish. You can diagnose it, you can focus it, you can store it, or not. You can break it, right? You can replace it with some recuts, you can annotate it, you can QA it, you can measure it, and count things on it, hunt for things on it. You can share it with 3 people, 4 people, more people, all right? Or there's an alternative, right? You can scan the glass, right? And that gives you a whole bunch of other opportunities than just the sharing piece of it, right? And so there's things that glass does better and things that the virtual slide does better.